Welcome to ASIN's Journal Club, episode 55. I am Dr. Z, here with KC, and today we are tackling a trial that pokes at a rule most of us learned early in training. The rule is, in aortic stenosis, you replace the valve when the patient becomes symptomatic, and until then you watch and wait. The trial is early TAVR, presented at a major interventional cardiology meeting in late 2024 and published in the New England Journal of Medicine in early 2025. KC, set the stage for us.
So, aortic stenosis is the most common valve disease, we admit. The classic teaching is built around symptoms. Once a patient with severe aortic stenosis develops the classic triad, exertional breathlessness, chest pain, or syncope, their prognosis falls off a cliff, and valve replacement becomes a clear indication. But while they are asymptomatic, the traditional thinking was that the risk of the procedure outweighed the risk of waiting, so we surveil them with regular echocardiograms and clinic visits.
Right? And two things have shifted that calculus. First, transcatheter aortic valve replacement has become dramatically safer and less invasive than open surgery. Second, we have come to realize that asymptomatic is a slippery word. A lot of these patients quietly stop climbing stairs or walking the dog, tell us they feel fine, and then show up in our emergency department in forward heart failure or after a syncopal episode. Early TAVR asked, what if we intervene earlier before symptoms in carefully selected patients?
And they were careful about defining asymptomatic. This was not just asking the patient in clinic. They randomized 901 patients with severe aortic stenosis who had a preserved ejection fraction of 50% or higher, and crucially a negative treadmill stress test to confirm they truly had no exertional symptoms. That stress test requirement is a much higher bar than a casual conversation.
That detail matters enormously, and we will come back to it. So 901 patients randomized 1-to-1. Tell us about the two arms.
One arm got early transcatheter aortic valve replacement using a balloon expandable valve. The other arm got active clinical surveillance, meaning visits every 6 to 12 months, with valve replacement triggered if and when they developed symptoms or met other guideline criteria. This was done across 75 centers in the United States and Canada, and the median follow-up was about 3.8 years. The trial was funded by the valve manufacturer Edwards Lifesciences.
And the primary outcome?
A composite of all-cause death, stroke, or unplanned cardiovascular hospitalization. And the headline result was striking. The composite occurred in 26.8% of the early replacement group versus 45.3% of the surveillance group. The hazard ratio was 0.50. On the surface, that is a halving of risk.
A halving of the composite. Now, this is the moment where a good resident slows down and asks the most important question in trial appraisal. Casey, what is that question?
What is actually driving the composite? And when you open it up, the answer changes the whole story. The difference is driven almost entirely by unplanned cardiovascular hospitalization, which was 20.9% versus 41.7%. All-cause death was basically identical, 8.4% in the early arm versus 9.2% in surveillance, not significant. And the stroke difference, for 0.2 versus 6.7%, was a favorable trend, but not statistically significant.
So no mortality benefit. Let that land. At a median of nearly 4 years, early valve replacement did not save lives compared with waiting. The entire engine of that beautiful hazard ratio is hospitalization, which is a softer endpoint and one that is sensitive to how the trial was designed.
And there is an even bigger wrinkle. About 87% of the surveillance group ended up getting a valve anyway during follow-up at a median of around 11 months. So this is not really a trial of valve versus no valve. It is much more a trial of valve now versus valve later.
That reframing is everything. Now versus later. And here is the clinically worrying part. A substantial fraction of the surveillance patients crossed over to get their valve only after they had already developed acute or advanced symptoms, like decompensated heart failure or syncope. In other words, waiting sometimes meant waiting until a bad presentation. Avoiding those acute presentations is a legitimate goal, even if mortality at 4 years did not differ.
So how do we weigh that? Is this a positive trial or not?
It is genuinely both, depending on what you ask of it. If you ask, does proactive replacement reduce death or stroke? The answer is no, not demonstrated. If you ask, does an early strategy reduce unplanned hospitalizations and acute decompensations? The answer is yes. The honest framing is that early TAVR makes earlier intervention a reasonable option to discuss, not a mandate. And there is an important counterpoint trial.
That is Evolved, which came out around the same time. Evolved also studied early intervention in asymptomatic severe aortic stenosis, but it selected higher-risk patients using cardiac magnetic resonance imaging to look for myocardial fibrosis. And Evolved was neutral. Its primary composite did not show a significant benefit.
Which is a humbling contrast. It suggests the benefit of an early strategy may depend a lot on which asymptomatic patients you pick and how you define their risk. 2 trials asked similar questions, got different answers. That should keep us measured. Let us talk limitations more broadly. KC.
Beyond the no mortality benefit point and the high crossover, the population was over 95% white and enrolled at high-volume structural heart centers in North America. So generalizing to community hospitals and more diverse populations is uncertain. The valve was used investigationally for this asymptomatic indication. And the procedure is not risk-free. There was roughly a 6% rate of new pacemaker implantation, plus small but real periprocedural stroke and death rates.
So how does this land for us as hospitalists, who are not the ones implanting valves? The first lesson is about that word, asymptomatic. When you admit a patient with known severe aortic stenosis who says they feel fine, push on it. Have they cut back on activity? Do they get short of breath on exertion they used to tolerate? The trial used a treadmill stress test to define asymptomatic precisely because patient self-report is unreliable.
And the second lesson is about not letting these patients fall through the cracks. If we find incidental or under-monitored severe aortic stenosis on an admission echo, the action is to make sure that patient is connected to a structural heart or valve clinic for follow-up, rather than discharged with a vague plan.
Exactly. And the third lesson is restraint in interpretation. Early TAVR does not mean we should be sending every asymptomatic patient for a valve. It means early intervention is now a legitimate option to raise with the heart team, framed as shared decision-making that weighs the procedural risk against the risk of an acute presentation down the line. The current valve guidelines still reserve the routine replacement indication for symptomatic disease, and they predate this trial.
So practically, on rounds, confirm whether the patient is truly asymptomatic, refer to the structural heart team, and frame it as a conversation rather than a reflex.
Well said. Early TAVR is a fascinating, important trial that should change the conversation without changing it into a slogan. Earlier intervention reduces hospitalizations and acute presentations in carefully selected asymptomatic patients, but it has not been shown to save lives, and the right patient selection is still being worked out. Thanks, KC. We will see everyone in the next episode of Asymptomatic Journal Club.